All right, so thank you everyone who's attended the seminar today. Today we have the wonderful Professor Flecknoe-Brown with us, who is a general physician but also a haematologist. While he's been in private practice for quite some time, he also has been doing medico-legal assessments since 1985. Hematology is a bit of a grey area for most of us, but it's generally relating to the management of blood in general and what can go wrong. In this case, we'll be talking about blood thinners. Some general housekeeping before we commence. Just like everyone to remain on mute through the duration of the seminar. At the end, there will be the opportunity for you to ask some questions. Without any more to say, I'd like to pass on to the amazing Professor Flecknoe-Brown to talk to us about the perils of blood thinners.
Thanks, Abby. And you'll notice that I've put the term blood thinners in inverted commas. That's because I consider it a, well, not exactly lazy, but rather far too convenient shorthand for a group of medications that have a whole lot of different effects on the blood coagulation function. Those of you who attended my last webinar will have been aware of the way a very complex and wondrous mechanism is brought into play when something breaches a blood vessel or something pinches the inside of an arterial vessel. And these various processes can be influenced in various ways. They have different effects, they have different indications. So I'm a bit wary of using the term blood thinners. First of all, they have no effect on the blood viscosity at all. The only way you can actually make the blood thin is to make the patient anemic. And for that matter, the only way you can make the blood thick is for them to become dehydrated, for them to have an abnormal process which results in proliferation of red cells, or a different abnormal process that results in the development of high levels of protein in the plasma of the blood. But none of these drugs that people, conveniently call blood thinners actually work on the viscosity or the thickness of the blood. Yes, they slow down in various ways the processes that are involved in production of a solid clot from liquid blood. We went over those in our last session, but basically the beginning of that process, once the early process of squeezing off of the blood vessel in question occurs, the first thing that happens is platelets, the little particles in the blood that are flowing around, normally shaped like discs and not having any trouble with the circulation at all, change into burr-shaped things which drift out of the circulation, stick to each other, and eventually form a raft-like thing that seals off the breach in the blood vessel. And on top of that, because of chemicals that they produce, there's a whole series of processes which amplify these signals and result in soluble fibrinogen, which is a protein in the circulation, turning into insoluble long strands of fibrin, which in turn trap up other substances in the blood, more platelets, red cells, and eventually leads to a clot. We all need to form clots. A clot that seals off the injury. At the same time that this is happening, there are another series of enzymes that are activated by the same activators, which are there in the blood itself to limit and digest the clot. And so it's the balance between the forming of the clot and the dissolution of the clot that leads to the eventual size. And in most cases, it's happening to us, probably minute by minute. In most cases, these little clots just form at exactly the right size. They're formed by the clot-forming enzymes and sculpted by the clot-digesting enzymes, and they cause no problem. But if the thrombotic process, the clotting process becomes dominant, then that clot can can basically propagate into the blood vessels and cause a deep vein thrombosis. In the case of coronary artery disease or atheroma in the vessels, the arterial vessels that supply the brain, the problem is not that the platelets are responding appropriately to a hole in the edge of the vessel. They're responding to the pinching of the side of the vessel from the deposit, the plaque, which causes turbulent flow. And this is important, it's high shear. In other words, in arteries, the blood is running much faster in the center than on the outside. That's high shear. In veins, the blood is running slowly in the middle, and so it's low shear. There's different amount of there's a significantly different differential between the speed of the blood vessels of the blood in the center of the vessel. So in high shear arterial flow, if the artery gets pinched off, that alone can activate platelets, and that in turn can lead to thrombosis, which is heart attack, strokes, and so on. So here we are already looking at the classes of drugs that can affect the process of clotting, of which the first is aspirin, which affects platelet activation and adhesion, and is used for preventing arterial thrombosis. In addition, there is the second class of drugs, which works through a different chemical mechanism on the platelet, and therefore really just affects the adhesion of the platelets to each other. But aspirin and these other drugs, of which the best known and most used is clopidogrel, work together to increase the amount of inhibition of platelet adhesion. And so you can prevent arterial thrombosis with either a single or dual antiplatelet therapy, but it takes the dual antiplatelet therapy, aspirin plus either clopidogrel or one of the other ones, prasugrel, ticagrelor. It takes a dual approach to prevent blocking off of a stent that's been placed artificially by a cardiologist or a vascular surgeon. And there's a period of time for which that is absolutely necessary that the dual antiplatelet therapy is continued so that the stent doesn't block off and become useless. So then we go to another class of drug, unfractionated heparin. And I've separated the two types of heparin because there are distinctly different mechanisms by which they work. Unfractionated heparin, which a lot of people just call heparin, first of all, it has an active end which removes activated clotting factors from the system straight away. As soon as it gets into the bloodstream, it forms a covalent bond with a circulating substance called antithrombin 3, and that complex will snap straight onto any activated clotting factors that have been released from the clot and might otherwise add on to the clot and propagate the clot and cause a thrombosis. So unfractionated heparin, and for that matter, low molecular weight heparin, very quickly work to prevent propagation of a thrombosis within a blood vessel. And it's because they're in the blood that they do that. Unfortunately, unfractionated heparin also has another effect because unfractionated heparin is a huge number of a huge number of molecules of different sizes. So the low molecular weight heparins have been chemically separated out so that there's only, in the case of Clexane, there's only somewhere between 15 and 25 repeats of the heparin subunit, and they don't have big long strands that can overlay the coagulation complex that forms when activated clotting factors interact with the vessel wall and a calcium ion. When heparin's in the system, it does interfere with that, so it does actually slow down clotting as well. And that can be measured by a blood test, which you may have heard of, called APDT, activated partial thromboplastin time. This is one of the important things to understand about the difference between unfractionated heparin and the highly purified heparins like Clexane. The highly purified ones aren't long enough to do that, to interfere with the formation of the clotting complex. So they don't affect the APTT. They're purely for either the prevention or treatment of venous thrombosis. You can imagine if the full dose of Clexane mops up every bit of activated clotting factor that's in the system, and there's a lot because, as I explained before, they're activated during the clotting process. And if they spill out into the system, you need, if it's formed a thrombosis, there's a storm of thrombosis going on, a storm of activated clotting factors being formed. You need a lot of Clexane around to mop them up, but it does. But if you use a lower dose of either Clexane or unfractionated heparin, you can catch the occasional one that escapes and prevent thrombosis from occurring. So there's two uses of heparin or Clexane, but Clexane is a little bit better. A little bit causes less bleeding and is more effective in preventing thrombosis than unfractionated heparin for reasons that are as much to do with the heterogeneity of the huge amount of different molecular weights of heparin in unfractionated heparin and the relative purity of the Clexane. The next one I mentioned is warfarin, and I've again separated that from the other oral anticoagulants because its action is different. It acts by inhibiting the formation of a family of coagulation factors. These coagulation factors normally circulate in inactive form, and they are part of the process when they become activated. They are part of the process that activate other clotting factors and produce this big response to a small signal. They're the vitamin K dependent factors, and warfarin antagonizes the formation of those factors in the liver from dietary vitamin K. It is useful. Well, it was the only thing we had that was an oral anticoagulant up until about 20 years ago. Nowadays, the only true indication for warfarin is either in preventing clots on mechanical valves, which the other oral anticoagulants are not powerful enough to do, and in this unusual but important, highly in a good formed case, highly thrombotic process called phospholipid antibody syndrome. You need warfarin for both of those, unfortunately. Because warfarin's a difficult drug to use. You need the person to have a reasonably stable lifestyle and not binge on different types of foods or alcohol for that matter. And they need to have regular blood tests to check that they're in the therapeutic range. Whereas this next group of anticoagulants, the direct-acting oral anticoagulants, or what used to be called novel oral anticoagulants, I suppose after 20 years, you can't call them novel anymore, but they work to actually antagonize one or other of the activated clotting factors. Most of them two of them in Australia, 3 of them in the world, work against activated factor 10, which is the one that activates the last of the clotting factors. And one of them, dabigatran, works directly against prothrombin turning to thrombin. So in either case, they are very effective and easy to use for the treatment of thrombosis or stroke prevention in atrial fibrillation. I'll just come back to that because I made the distinction earlier on between the way platelets become activated to trigger thrombosis in arteries, and it's the slowing down of blood and the injury to the blood vessels and some situation that makes the blood a bit more inclined to clot that leads to deep vein thrombosis. It turns out that atrial fibrillation is a situation where the top chambers of the heart, the atria, are quivering rather than pumping. And that leads to stagnation of blood flow through those little auricles at the top of the heart. And clots can form in that stagnant blood. So that's, although that is more like the situation with venous thrombosis. It is due to stagnation and effects on the stickiness of the blood. And for that reason, warfarin and the direct-acting oral anticoagulants work in AF in preventing those clots forming, even though the big danger of that clot is that it'll flip out from the atria into the ventricles and be pushed out in the arterial circulation and cause a stroke or an ischemic leg or an injury to the kidney or something like that. So although the manifestation of thrombosis in the atrial appendage in a person with atrial fibrillation, AF, although the manifestation is in the arteries, it is the venous type of anticoagulants that you need to prevent it. And when these drugs were introduced, the big blockbuster indication for them was stroke prevention in AF. They're also useful for treatment of deep vein thrombosis, but there's a huge number of people over the age of 60 with atrial fibrillation, and stroke prevention depended on warfarin up until then. So it was a big opportunity. The point is that it was compared against aspirin, and aspirin, and for that matter, dual antiplatelet therapy was totally insufficient to prevent strokes in atrial fibrillation, whereas these things are brilliant. These ones, warfarin's good too, but warfarin has more bleeding and more strokes than these more direct-acting oral anticoagulants. So it's not just easier, they're not just easier, they're better for stroke prevention in AF, and they're better also for treatment of venous thrombosis. And finally, perhaps not really called a blood thinner by those people who want to collect all these things under one umbrella term, there are drugs that we can give that actually bust the clots. Thrombolytic drugs. Now, these, if you like, these are genetic engineered pure enzymes that are of the type of enzyme I was talking about, which helps to sculpt the size of the clot. So these drugs actually digest, eat into an established thrombosis, and within minutes to half an hour, they have digested the entire clot. So they're very useful in treating a heart attack, stroke, or life or limb-threatening venous thrombosis. So most people call them clot busters or thrombolytic drugs, but they still act on the blood coagulation system, and it's something you need to be aware of. It'll come up from time to time. Let's have a look at the next slide. This is the point. Why does it matter? Because the antiplatelet drugs don't protect against low shear or venous thrombosis. They don't protect against strokes in atrial fibrillation, and they don't protect against deep vein thrombosis. I've given you this example here of the Charles de Gaulle Airport Medical Centre, and I love telling this story. In 2001, a group of people from the Australasian, which I presume is the aviation hospital, reported on a big observational study of people hauled into their emergency department from the Charles de Gaulle Airport Medical Centre. And this group of people were able to demonstrate that the further a traveller had come before reaching the centre of the universe, that's Paris, of course, the further they had come, the more likely was deep vein thrombosis or pulmonary embolus to have occurred. So that those who travelled only 500 kilometres or so had a 0.1% incidence of DVT or pulmonary embolus, and it rose to, I think, 1% at up to 5,000 kilometres, and it was there was a significant gradient once you got above 10,000 kilometres of air travel. So that was picked up by the New England Journal of Medicine. It was very important because we've been speculating about economy class syndrome and what this business of thrombosis with air flight was, and these people proved very well that this was the story. A few years later, the same authors wrote to the New England Journal saying, well, in effect, please tell your readers not to keep using aspirin to try and prevent DVT because it's not working. We're still seeing as many DVTs, but we're seeing 10 times the number of people taken off planes with gastrointestinal hemorrhage from an aspirin side effect. So aspirin wasn't protecting them, but it was causing problems if people were thinking that aspirin would protect them against a thrombosis in a long haul air flight. Just an anecdote, but it certainly is true that whilst a group of Australian researchers have shown that beyond the therapeutic phase of treatment of deep vein thrombosis, beyond that point, you can reduce the rate of recurrent thrombosis, venous thrombosis, by a proportion. It is not effective treatment of deep vein thrombosis, and it's not effective, not really a very effective treatment for prevention. At the moment, another anecdote, I was asked to testify at a coronial inquest about a woman who had died after joint replacement surgery from pulmonary embolism. And I had been critical of the fact that she had been treated with aspirin as the protection. Well, the coroner managed to find a good, honest workaday orthopaedic surgeon who was able to say, well, this is what we usually do and this is why. But also the person who had convened the Australian Arthroplasty Association working group to get the new guidelines that have been published in 2015. And these guidelines actually stated that aspirin was a reasonable form of protection after hip and knee replacement surgery. I took them on because the guidelines were based on observational studies. They were based on vast numbers of people who had been put into joint replacement registries in Europe, the US, and here in Australia, hundreds of thousands of people. And the problem with that is that was not randomized. So it was up to the choice of the surgeon whether they were going to be protected with aspirin or the more effective Clexane. So already there was selection bias as to who was in which group. The ones who the surgeon thought were at higher risk were already given the Clexane. But there was also potential for ascertainment bias, because if it's a registry study, how do you know that there weren't people who developed DVTs later on who didn't get into the register? So sure enough, it was informative to the coroner and to the family, but we parted without completely agreeing on what was the best way to protect after deep vein, after joint and hip replacement surgery. A year later, a group led by Australians published a properly scientifically conducted study, randomized controlled study, prospective. And sure enough, there was an increase in the rate of DVTs in the aspirin group compared to the Clexane group. And these were deliberately low-risk patients having low-risk surgery. There was still a significant increase in the number of deep vein thromboses. But, said everybody who still wanted to avoid Clexane, but they were only little ones. They didn't matter. Well, they do matter. The ones below the ones that form in the veins below the knee can propagate up and can cause venous thromboembolism. Pulmonary embolism, although most of them didn't. The other thing is that we then showed that was then shown that isolated below knee thromboses can propagate and can go on to cause problems. So I don't think that the publication of that study, which again was in the New England Journal of Medicine, I don't think that study changed practice. People had already made up their mind on the basis of operating theatre tea room chatter that this stuff causes bleeding. This Clexane, we don't like this, and yet again, this properly scientifically done study showed no difference in bleeding rates between the Clexane group and the aspirin group. So the point is that I still say that the antiplatelet drugs aren't as good at protecting against deep vein thrombosis as the anticoagulants like Clexane. Similarly, heparin and the oral anticoagulants aren't useful in arterial thrombosis because the problem is platelet activation. And the way to protect against that is to disable the platelets to a certain extent or a large extent, either with aspirin or with dual antiplatelet therapy. So heparins don't make a difference in stroke and transient ischemic attacks. In fact, heparins are now considered bad practice in a person who's just had a stroke, because the brain is not like the heart. The brain is a soft, very, very pulpy organ, and after a stroke, the part of the brain that's been affected can become disorganized, and the blood vessels can become disorganized and bleed. So heparins are not a good idea after stroke, and hardly anybody uses them. There was also a fad for using warfarin after a heart attack. It was particularly popular in Europe. And again, it seemed to make sense to the people who were enthusiasts for the idea, but it didn't make a difference in the outcomes, that it did cause more bleeding. So it's been abandoned as an approach. Next, please. So the next question that we need to be aware of in the use of these antithrombotic, geez, I made this mistake myself. The next thing we need to be aware of in the use of these is, what is the optimal duration? That's important because every one of these drugs can increase, intuitively, obviously, bleeding episodes. So if you need to use them, you use them for the appropriate period of time, not longer. And I'll give you some figures on that later. So we make a distinction between provoked and unprovoked thrombosis. If a thrombosis occurs in an obvious situation like surgery, serious medical illness, putting a person to bed, long-haul air travel, then that's a provoked thrombosis, and a shorter duration of treatment is indicated with a direct-acting oral anticoagulant, or warfarin if you prefer it, but I don't. No, I don't recommend it. If it's a big clot, if it's a big thrombosis, a full length involving the whole leg, or if it's become a pulmonary embolus, again provoked, then the recommended duration is 6 months. And before stopping it, there are a few procedures, a few tests that I recommend that people go through, the GPs go through, to make sure that it is safe to stop it. On the other hand, there is now compelling evidence, it's been around since 2021, that says that a first unprovoked pulmonary embolus, in other words, one that's come out of the blue for no obvious reason, this is accompanied by something like an 18% per annum cumulative recurrence rate. That is just unacceptable. If you give them 6 months and then stop, then for the rest of their life, they're counting the time until the next one comes along. So it's much better, particularly now we have very good, safe, and not terribly hard to use anticoagulants like the direct oral anticoagulants. The current recommendation is lifelong. Now, we'll go to the antiplatelet drugs, the aspirin and clopidogrel dual antiplatelet therapy. Dual antiplatelet therapy is really only indicated for either 3 months for certain types of stents, or 12 months for other types of stents. And I said cardiac stent, but I will agree that the stents that vascular surgeons put into carotid arteries or into legs, it's the same duration. After that, it's been very clearly demonstrated that you don't get any additional benefit, but you do get more bleeds. And why would you ask for that? Similarly, there is a recommendation, a current practice of using dual antiplatelet therapy following transient ischemic attack. Some people call it a mini stroke. It's an episode where a person looks like they've had a stroke and then it goes away within minutes or hours. The recommendation there is 3 months. And again, beyond that, there's no benefit. I get very frustrated when I see patients coming into hospital who've been on dual antiplatelet therapy for years after one episode of TIA or after a cardiac stent, because it's no benefit to them and it's running an extra risk. I'll give you some numbers on this later. And finally, atrial fibrillation. Atrial fibrillation is an interesting one. You can certainly say that people with atrial fibrillation are at risk of a stroke, either intermittent, that one that comes and goes, or continuous atrial fibrillation. But the risk of stroke varies according to a number of other factors, and this can be put into a risk calculator. And well, you can get an idea of the risk. It is in the order of 1% per annum. In other words, one stroke per 100, is it 100 patient years? No, per 10 patient years. No, sorry, per 100 patient years, yes. It's in people who've had been treated with blood pressure or diabetes, it rises to 3 or 4% per annum, or that is it, yeah, 3 or 4 strokes per 100 patient years of treatment of atrial fibrillation untreated. And then it starts to sort of cross the line with the risk of bleeding associated with either warfarin or the direct-acting oral anticoagulants. I'll give you some numbers on that later. But the point is that this is not something which a doctor should just write a prescription for and say nothing to it about the patient. Here, I'll put you on this medication. And that so often happens. And I find that particularly among cardiologists and neurologists, I suppose, because they've seen people have strokes in front of their very eyes in atrial fibrillation, so they're very sensitized to it. But the proper practice, in my opinion, is to sit down with the patient and say, look, you've got this condition and explain what's going on, how the blood can become stagnant in the heart because of this fibrillating atria, and the clots can flip off and cause strokes. And we know in your case that there's about a 3.5% risk per annum of you having a stroke. And it continues year after year. So 10 years down the track, it's getting to 30%. Now, on the other hand, if I give you a medication, I can reduce that risk to almost zero. But it carries with it a risk of bleeding. That bleeding typically, we'll again discuss this later, that bleeding typically occurs, most commonly occurs in the gut, and it can be dealt with, but it could occur in the brain and cause a hemorrhage in the brain. So you need to know this, and because you're the one who's got the risk and you're the one who's taking the medication. This is the sort of discussion I like to see happening, but it rarely does. And I've used the term until senescence because there is compelling evidence that continuing anticoagulants beyond the point when a person is either becoming demented and falling about the place or in a nursing home, that is hazardous. That's when it should be stopped. Next slide, please. That's the threat with using anticoagulant drugs either properly or excessively. A bleed, and that is the most fearsome bleed, although it's not an extreme example of it. That's a bleed into the brain. Next, please. So the sites of bleeding that we can see are Well, anybody who's known a person who's taking either, aspirin or dual antiplatelet therapy or oral anticoagulants will probably have observed they tend to bleed a little bit longer from a little cut, or the bruise is probably twice as big as it deserves to be. But that's just a nuisance. It's easily dealt with. The patient needs to be aware of the risk of it, but it's not going to stop them from doing what is in their interest. The commonest source of major bleeding, as defined by bleeding needing a transfusion, bleeding leading to a significant drop in the hemoglobin reading, that's the red cells, or bleeding into a critical place like the spinal cord or the brain. That's the commonest cause of that major bleeding is from the upper gastrointestinal tract. And typically all you need to do is stop the anticoagulant and give a substance to antagonize production of stomach acid. But a muscle hematoma, a big bleed into a muscle, can be terribly painful and can actually be debilitating or lead to chronic disability. Not usually, but that's the next commonest one. And in the direct acting oral anticoagulants, intracranial bleeding is uncommon, rare, unless the patient is inclined to fall over and bump their head. We don't do that deliberately, of course, but as you get older and frailer and lose your balance, that becomes a risk. But spontaneous intracranial bleeding with the direct oral anticoagulants is a 0.1% risk per annum, not very high at all. Whereas with warfarin, it's something like a 1% risk per annum. Next, please. So the rates of major bleeding in these various blood thinners classes, these various types of antithrombotic medications, unfractionated heparin causes more major bleeding than the low molecular weight heparins like Clexane. Warfarin causes more bleeding than the direct oral anticoagulants. It's probably the same reason as the direct oral anticoagulants are more effective than warfarin, because warfarin, the effect of warfarin fluctuates with diet, with medications. A short course of antibiotics can have a devastating effect on the warfarin effect on the blood test that you measure for warfarin. So probably the reason that warfarin is a little less reliable than the direct oral anticoagulants is in the clinical trials that were done, every patient took every dose. Well, sorry, every subject on the direct anticoagulant arm took every dose, and so they had proper anticoagulation all the time. Whereas in the warfarin arm and in real life practice, people are only in the recommended therapeutic range for about 60-70% of the time. So the rest of the time they're either not getting enough or they're getting too much. And that's why the direct oral anticoagulants were hunted for years. We worked for decades to try and find a good one. And now we've got 3 good ones in Australia and there's a 4th overseas. And they cause less bleeding and definitely much less intracranial bleeding than warfarin. Dual antiplatelet therapy causes more bleeding, more major bleeding than either aspirin on its own or clopidogrel on its own. But there's a period of time where it's worth taking that, accepting that hazard, because you don't want that stent to clot off. And there's a dreadfully high rate of bleeding, major bleeding, if a person is on, say, an oral anticoagulant for chronic atrial fibrillation. And remember, I said it's a condition of the heart. So these are people who may have a dicky ticker in other ways as well. So they might have a heart attack and need a stent put in. Then you've got a problem, because you need the protection of the dual antiplatelet therapy to protect the stent for a period of time. But you've got the risk of stroke, the background small risk of stroke. But if you add all 3 together, various studies have shown that the major bleeding risk is between 8.8 and 10.4 10% per year, or 10 bleeds per 100 patient years. And that's a number that none of us are very comfortable with. So we've worked on various ways of mitigating that risk and getting it down below 5% for the short period of time. And the cardiologists are working on ways of shortening the the recommended duration of dual antiplatelet therapy after a stent. So this is an idea of the issue of bleeding, and now we've got a gradient of the risk of bleeding with various either alone or combinations of anti-thrombotic treatments, blood thinners, and this gives you an idea of both the real issue and the nuance of that issue. Nothing's free in medicine. You do need to give anticoagulants. Well, it is advisable to give anticoagulants in the case of atrial fibrillation in most cases, and there are times when it's absolutely life-saving in others. So you have to accept a risk as long as the risk is known, and as long as the risk is not made greater by prolonging the treatment beyond what is advisable. That may be about it. Let's have a look. Next slide. Oh, yes. Oh, I love this one. This is a slide that shows you in very graphic terms the bleeding rates by age. It's from one of the studies. There's a lot of studies out there showing this, but you'll see along the bottom axis the various options: no anticoagulants, warfarin, DOAC. This was in the early days. Remember, this is a 1995 to 2015. The direct oral anticoagulants were only just being introduced, so the numbers on the DOACs are a little bit rubbery, but certainly we knew pretty firm figures on warfarin, aspirin alone, then dual antiplatelet therapy, that green box, then the warfarin plus an antiplatelet drug, the DOAC plus an antiplatelet drug, and getting right over to the left, triple therapy using warfarin and triple therapy using DOAC. Big high rates, 20% bleeds in the 80s. Well, sorry, people above the age of 90. So the rate of bleeding rises with the number of drugs, but also with the age of the patient. And this really graphically illustrates how people have got to use the evidence and discuss carefully with the patient what the hazards are when various forms of anticoagulation are used. This is a really good illustration of the bleeding risk, the additional bleeding risk from adding extra antithrombotic drugs as the patient ages. Good. Is that nice and clear? There are a few caveats. Caution should be used with extremes of body weight. Very thin people below 50 kilogram in weight, or very big people who are over 130 kilogram in body mass, or over a body mass index of 35 kilogram per square meter, need different dosing. Similarly, both the low molecular weight heparins and the direct oral anticoagulants are cleared by the kidney. So caution should be used in the dosing of both of those drugs in patients with kidney failure. In the case of the direct oral anticoagulants, the liver metabolizes them also, so they can accumulate in a person with liver failure. And again, I've emphasised that when a patient is started on anticoagulants for atrial fibrillation, a proper informed consent discussion should take place. The patient should be informed of their stroke risk, untreated, of the bleeding risk, treated, and then the patient's preference taken into account. Most of us would fear the threat of a stroke It would come as much more of a threat. It would be weighted much higher than the risk of bleeding, which us clever doctors can fix up at the time. Although you would say the risk of bleeding with some of the anticoagulants is 3.3% per annum, there'll be a person whose calculated stroke risk is 2% per annum who'll still say, thanks very much, I'll have the anticoagulant and accept the risk of bleeding, if the discussion is had. And unfortunately, it usually isn't, which will lead to problems down the track, I'm sure, for all of us. Here we go. Sorry, yes. So in the case of bleeding, this is what we do. We stop the drug. There are drug reversal agents available for all the types of antithrombotics, but in the case of intracranial bleeding, it has been shown recently that use of the newest of the approved bleeding reversal agents in direct oral anticoagulants like rivaroxaban and apixaban, and it works for Clexane as well. But reversal of those drugs does not affect the outcome, either death rate or degree of physical recovery in the case of intracranial bleed. The damage is already done by the time the diagnosis is made, and reversal of the anticoagulant doesn't help the patient's recovery, but it does stop the bleed getting bigger. So that's, I think, the end of it. Thank you.
Perfect. So we did have a question, I believe, from Michael pop up. So feel free, Michael, to unmute yourself and ask the questions you had.
Oh, yes. The question was the post-stent, there was some medication, the dual anticoagulant thing. I was just wondering how long that should stay on for.
I provided the answer, but I didn't provide it in detail. There are two different types of stents, and the cardiac stents that are used most commonly these days are the what's called drug-eluting stents. They have a medication embedded in their material, which slowly trickles out from the stent itself and prevents the growth of materials over the stent that would provoke thrombosis. In the case of the old bare metal stents, you only need dual antiplatelet therapy for 3 months. The recommended duration for the drug-eluting stents is 12 months. But I think I also mentioned that a lot of my colleagues in cardiology are working on trying to find a way of shortening that duration, because they're conscious of, first of all, the risk of bleeding, and secondly, the interaction. A lot of their patients are now already on anticoagulants for atrial fibrillation, so that interaction they're worried about as well.
Right.
So that's the answer. 3 months for some, 12 months for others, but the duration will probably come down as more studies come in.
Great, thank you.
Awesome. I actually did have another question that you didn't touch on, but I would be curious to know. We've spoken a lot about the drugs that we use for blood thinners, but in terms of herbal remedies, I have heard that fish oil can act as a natural blood thinner. Do you have any other herbal sort of stuff that people might be taking for surgeries they possibly should disclose but wouldn't think to disclose, stuff like that?
Good. Fish oil, which has been disproven as actually having any beneficial effect on longevity or heart attack rate, but the rheumatologists like to prescribe it for arthritis. It does have some beneficial effects there, but fish oil is not really a protection. It's the whole fish that improves your heart health, or the whole olive oil, or the whole avocado. Those sorts of good oils should be taken in their natural form rather than as a purified substance. But yes, it's true. Fish oil supplements will have trouble with, they will interfere with coagulation in the surgical circumstance. They'll cause extra bleeding in patients having surgery. So that should be disclosed. There are a number of other herbal substances that interact, particularly with the direct oral anticoagulant drugs. The famous one is St. John's wort. I don't know if anybody's heard of that, but WORT, St. John's wort. And that definitely interacts with a whole lot of medications, but it interacts with the direct oral anticoagulants and causes the levels to go up, which means, of course, that they're more effective and more inclined to cause bleeding, but no more, well, they can't prevent clotting any further than they do, thrombosis any more than they do. So those are the only two I can think of. And I'm glad you mentioned it, because fish oil, if a person's taking fish oil, they should make sure they tell their surgeon about it, and and it's probably not a good idea to continue on it if they're started on anticoagulants of any sort.
Perfect. Well, thank you for that. If there's any further questions, I don't think there's anyone else. But no, I would like to say a big thank you for your time today, Professor Flecknoe-Brown. It's been amazing to hear on this topic, something I definitely haven't given as much thought to until today. So you've provided really great understanding. I'm sure we'll benefit off that. So thank you a lot. And thank you to everyone that's attended as well. This is an amazing seminar. It's great to have you here as well to witness the greatness and the expertise that we have in our panel at MAG.
I saw the olive tree on your over your shoulder there.
Yes, it's a fake one though.
Oh.
Perfect. All right. Well, I'll stop the recording there.
Okay. Thank you.